Good morning or good afternoon to everyone. Thank you for joining us for one of our educational webinars. This one is presented by Orfit on pediatric patient immobilization and very timely considering it is Childhood Cancer Awareness Month. For those that don't know me, I'm Jennifer Majori. I am the Executive Director for the National Association for Proton Therapy. We are an independent non-for-profit association that represents 52 members that are delivering proton therapy or soon to be delivering proton therapy in the United States. And our core mission is to provide education and awareness of the benefits. And this is a perfect example of why we're here today. So like I said today, we are committed to supporting our members in delivering the highest quality care to their patients. And we do that through education programs like this. So we're very excited to partner with Orfit. They've been a phenomenal partner with us throughout the year. And this is a great example of them collaborating to provide education to the larger community. So I want to introduce Michael Pittman. Many of you know him. He's been in our industry for many years. Really excited that we can work with him today and that he'll introduce the great team we have here from Belgium. So Michael, I will turn it over to you. And also mentioning that the chat, the question and answer is open. Our panelists will see that. So feel free to send your question and answers throughout. Michael will manage that at the end of the webinar. So Michael, I'll turn it over to you.
Thank you, Jennifer. Hi, everyone, and thanks for joining us today. On behalf of Orfit, it's a pleasure to welcome you to this NAPT educational webinar. At Orfit, we believe progress happens when knowledge is shared. That's why we're so committed to supporting this webinar. Today's speakers are Leuven Raymakers and Annelien Huteber from the Particle Proton Center at the University Hospital Leuven in Belgium. They'll take us into their clinical experience with pediatric patient positioning, a topic that sits right at the heart of precision and care for proton therapy. We're excited to hear their insights and case presentation, so let's get started. Please join me in welcoming Leuven and Annelien.
So good afternoon and welcome to our presentation. First of all, thank you for joining us today. We're very pleased to have the opportunity to talk to you about our work and share some insights from our center. So like I said, my name is Leuven and I work as a radiation therapist at the Proton Therapy Center Particle in Belgium. And I'm joined today with my colleague Annelien Huteber, who is a medical physicist in our center. Together, we will guide you through a presentation about our Proton Therapy Center with a special focus on immobilization techniques for pediatric patients. As you all know, pediatric radiation therapy poses unique challenges, particularly when it comes ensuring precision and comfort for our youngest patients. We will share with you how we approach this in our center. These techniques and tools we use and some of the lessons we've learned along the way. So we hope you find the presentation informative and inspiring. Okay, so before we dive into the details, here is a quick overview of what we will covering in today's presentation. First, we will give you a short introduction to our particle proton therapy department, where we both work, and then we will talk about the patient immobilization devices we use in our clinical practice. We will follow that with a specialized focus on immobilization for pediatric patients, since it's particularly delicate and important part of our work. And finally, we will discuss how we tailor our immobilization approach to each individual patient, aiming for both precision and patient comfort. So let's begin with a look at our Proton Therapy Center. So before we look to our center in detail, it's important to highlight that the Particle Proton Therapy Center is a collaboration network of university hospitals across Belgium. This network ensures that proton therapy is available to patients nationwide. and that expertise and patient care are shared across institutions. The actual proton treatment happens in Leuven, where we both work. So at our center, we work with clinical EBI protease 1, which is a compact gantry system, specially designed for proton therapy. Since we have a half gantry, it's actually the patient who moves 180 degrees, you allowing us to irradiate both sides of the patient. In our treatment room, we have a protease 1 proton therapy system combined with an in-room CT scanner. There are only a handful of in-room CT scanners for proton therapy in the world. Notably, the treatment table moves to the other side of the room in the in-room CT position. To acquire the in-room CT, the patient stays stationary while the CT scanner moves on rails. This in-room CT is handy when we need to verify and possibly adjust the treatment plan. For example, if there are some anatomical changes or uncertainties, the CT allows us to recalculate the dose distributions fast, allowing us to adapt the plan to our patients. At the moment, it's still an offline process, but we would like to move towards an online process. So since we started treating in 2020, our proton therapy department has been dedicated to providing treatments to patients of all ages. But we take the pride in our specialized focus on pediatric care, with approximately 60% of our patients being pediatric patients. This highlights our commitment to delivering gentle and precise treatments tailored to younger patients. One of the key treatments indications we do on a daily basis is craniospinal irradiations, or CSI, which accounts for about 30% of our cases. CSI basically means that we need to irradiate the full craniospinal axis, consisting to the brain and the full spinal cord. There are generally lengthy treatment times due to the large axis that we need to cover, combined with the state-of-art imaging guided protocols. CSI is really one of those indications where you see the benefits in using proton therapy, minimizing mainly the dose beds across the thoracic and pelvic region. A part of the CSI indications, we mainly treat in intracranial indications. We also treat head and neck regions, paraspinal, and a variety of other indications. Looking at our data of the last 5 years, we have treated about 350 patients, with a majority being pediatric patients, excuse me. So to our balanced approach to treating both children and adults. So we'll now discuss the immobilization devices using during our treatments in our center. These devices ensure that the patient is positioned comfortably and insecurely, allowing us to precise and safe delivery of the therapy. Here you see a range of immobilization devices for intracranial, head and neck, and CSI indications. For treatments involving the brain, head and neck regions, CSI, precise patient immobilization is essential to ensure treatment accuracy and safety. So the adult patients receive the Q-fix immobilization base combined with a mold care cushion and either a head and neck or a head and shoulder mask. A knee support is also provided to added for comfort and stability. The pediatric patients are immobilized using the HP Pro system, the Van Cube from Orfit, which includes a 3-point and a 5-point mask and a mold care cushion. Depending on the child's size, a knee support also may be added. These customized immobilization devices allows us to achieve exact and reproducible patient positioning, which is critical for effective proton therapy in these delicate treatment areas. And for treatment starting the thoracic and pelvic regions, we use the K-View proton couch together with a wing board and a knee. And a concern thing for us as RTTs to check every treatment apart of the intracranial only indications are these Q-fix movable rails. These bars can never be in the beam entry path. So for posterior irradiations, we always have these in fully open position. In exceptional cases, mainly decentralized position target location, the physicists will calculate during the planning if a closed bar position needs to be applied during the treatment. Nevertheless, position needs always to be checked prior to beam delivery.
Oh, hi there. Thank you, Louise. Let's move on to our CT simulation moment for a typical intracranial or CSI patient. So we fixate our BOSS or HP Pro table insert on top of our CT couch, and our patient will get a mold care pillow under their head. This is a patient-specific moldable pillow, allowing both comfort and precise immobilization, combined with our immobilization mask, which then goes on top in a later phase. Together they form, or they should form, a stable but still comfortable patient's shelf. At least that's what we hope for, of course. But first step is molding our mold care. So when getting the freely moldable mold care out of the package, we normally spray some water onto this cushion when we treat this patient with photon. And this starts the hardening process of the material, allowing us to really mold that material. But to spread liberally water on any immobilization device during the CT simulation process is not really advisable for proton treatments. This would entice that water particles are present in the mold care during the CT simulation acquisition, which would then evaporate in the next week when our patient comes back for the treatment start. So since we use our CT simulation for precise plan calculation, having those water particles no longer there in the beam entry path would result in less range pullback of our brag peak, resulting in our patient's brag peak position being displaced. We look into ways to avoid using water in our immobilization process for this reason, and we found out that our mold care also hardens up from the natural flowing water particles in the air. So once we get the mold care out of its package, the hardening process is also started. It just takes a bit more time. So our RTTs spend about double the time to allow this hardening process to happen. So a bit more than 5 minutes to allow enough mold care hardening instead of 2 minutes. So when our RTTs move on to the next step, which is the molding of the masks itself, we use the same keep away from water principle. So this means instead of heating up our masks in the water baths, which is commonly done for photon use, we heat the mask in our Orfit provided dry ovens instead. And they worked quite well. Something we've seen in other proton therapy centers when they do not use the dry molding approach in their CT simulation is that the patient molding and immobilization happens on a separate day from the planning CT acquisition. So allowing any water particles in the immobilization devices to dry out by the time they reinstall their patients into the immobilization devices for the actual CT acquisition, but making the CT simulation a 2-day process. So for our young patients under anesthesia, this would mean an additional anesthesia session, which was something we wanted to avoid. So for our slightly older patients, generally above the age of 6, who don't need anesthesia, we find it important that we get to know our patients already. So taking more time during our one simulation session is actually seen as a good thing. And let's focus further on immobilization for pediatric patients, of course. Yeah, we've been clinically treating patients with proton therapy for over 5 years now, but when we tried to make ourselves really ready for our proton clinic about 6 years ago, we had a multidisciplinary focus on trying to get our patient immobilization just right for proton usage. We mainly focused on intracranial, head and neck, and CSI immobilization at this stage. So that means we were mainly practicing immobilization techniques on ourselves, whilst gathering feedback within our team. So that's the radons, RTTs, and MPEs. And I must say we practiced endlessly in order to feel more secure, and we did feel more secure in the end. But our testing was mainly focused on adult anatomies, since, our staff mainly consists of adults. We tried our immobilization techniques also on pediatric mock patients, meaning family members of our staff. And here we have my oldest kid at the time lying on top of the boss couch, and he was about 2 years old at the time. So we were able to practice our mold care technique a bit, so that dry hardening technique. But it was not possible to try out our full immobilization chain and have this tested, including attaching the mask. I can assure you, my 2-year-old kid would not lay still at the time for this. So we did what we could. And when we just went clinical back in 2020, we had an upcoming head and neck case for a 9-month-old baby. Since the target volume was tiny and really located in the neck region, we needed to avoid having neck folds for this patient. And since our patient was a baby, we could not really go for a full, hyperextension neck position. So we needed to find a kind of reasonable neutral neck position. And here you see when we had our patient here at CT simulation and under anesthesia, we did our best in achieving this neutral neck position whilst placing the shoulders at the most cranial part of the boss shoulder position as possible. But his head could somehow not nicely fill the boss cradle piece where the head is supposed to rest within the Q-fix boss system. So we were able to click a mask onto the foreseen boss pins, but the mask itself felt quite large for this patient and was not really offering a cranial stopper in terms of immobilization, and it felt to us a bit more like a tent. So I must say our Q-fix boss system is more of a one-size-fits-most tabletop system, but here for this specific, the fixed long region between the shoulders and the head cradle seems not really well suited for these really young patients. So even though in the end, this patient was not treated with proton therapy nor photon therapy due to both immobilization issues and actually mainly clinical issues, this patient did open our eyes that we wanted to improve our immobilization further for really young pediatric patients. So that's what we did, of course. And what we did is we had one of our 3D printing magician PhD students print out a bust of this exact patient that you've just seen before. And with this 3D print, we reached out to multiple immobilization vendors to help us further to improve them and practice immobilization techniques for young patients. And one of these vendors was Orfit. And as part of their HP Pro table inserts, they offer a variety of age-specific plates with a specific neck length, so offering shorter neck lengths for younger patients. And after testing all of the options with this 9-month-old baby, the HP Pro 0 to 7 years old combined with the 5 points Orfit mask felt retrospectively the best option for us for this case. And then we went further ahead and purchased this 0 to 7 years old HP Pro table insert for departments and use this combined with the Orfit masks. And with this purchase, we were able to confidently make a division between adult patient anatomy immobilization and our pediatric immobilization devices. So on top, we have our adult adult anatomy immobilization range, and in the bottom, we have our pediatric immobilization devices. And of course, we tailor our immobilization to our patients in more than one way. For our very young patients treated under anesthesia, the placement of the sedation nose goggles is placed through the nose opening of the Orfit mask, with the cabling fully on top of the mask, with some like strategic tapes to hold these tubes correctly into place. And for our patients older than 5-6 years old, the treatment generally does not happen under anesthesia. And for these patients, the RTT team already tries to get to know the patient during the CT simulation moment, so they take their time there. And by the time the patient comes back for their actual treatment start, they can tailor the mask further to the patient's interest, as you see here with this Paw Patrol mask. In my honest opinion, our RTT team is very creative in painting these masks into true artworks. Good job. Our patients are hopefully always surprised with a painted mask when they come for their first correction. And with this artistic compilation of painted artistic masks, I want to thank you for your attention. And of course, Leuven and I want to thank the full team who contributed in this presentation. Thank you.
Thank you so much. It was an excellent presentation and really appreciate the work. I love that your son is part of this process. It's like bring child to work day. That's great. So there is one question here. Any adaptive procedure or data available is done in your organization? I think that was just a little grammar typo, but does that make sense?
So can you repeat the question again? Sorry.
It says, are there any adaptive procedures or data available that is done in your organization?
Yeah, so there's several layers of adaptation with respect to this, immobilization focus in this presentation. So sometimes there's a need for adaptation which doesn't require a new mask. So a good example for that is like debulking of like a tumor due to good response of the radiotherapy or chemo or whatever. And there's a lot of debulking happening, but the mask is still fitting nicely. So then we can acquire an in-room CT and like efficiently plan on that. Sometimes, there is like a really patient loses weight, or patient like
Growth.
growth. That's also or there's some.
What was that you said? What was the last thing you said? Losing weight. What was the second thing?
Growing.
Yes, right.
Little children, we see that they grow during the treatment, and that the masks doesn't fit anymore.
And then we plan a new simulation session. So at our separate CT simulation, place, and a new mask is made at that time. So fitting, the new situation more precisely. So there's actually division there in terms of adaptation. But our in-room CT allows us for fast adaptation ideally one more back
at the moment, for the next day maybe.
Yeah, it's still offline, so if that's the question.
It takes a little bit time.
I think that'll answer. We'll see. There's another question though, so let's move to that one. Are you doing daily imaging with your CT on rails?
No, with the
should I? Yeah, maybe I should answer. So the way, maybe because it relates to a full image guidance protocols for our intracranial and CSI cases, which is the majority of cases that we do. There's definitely no daily or weekly even in-room CT. The in-room CT procedure is only triggered when there's an indication that something has changed. So we do weekly combing CT for those CSI cases, and if we see something happening to the anatomy, like really severely changing, then that would trigger an in-room CT. But it's for CSI cases, it's very rare. For in-room intracranial cases, it depends if it's more located
in the
the sinonasal region.
region, then it happens
More often.
more often.
Does that answer your question?
Yes, yes. Anything else that you should share with us around challenges or implementation things around the workflow piece? I know that's of interest to many of our centers as they're at capacity, trying to make sure they have workflow but still provide this precision care and use techniques like this.
In terms of workflow, I think for immobilization, it's definitely make sure everything is in your setup notes. You guys do such a great job at that.
We take notes and everything is on it. So where the cushion lies, or we take pictures. Sometimes it also helps because you can write it, but yeah, when you see it on the picture, it's more clear. So yeah.
Okay, so a couple more questions coming through. So as people are thinking through this, one of the questions is, how do you quantify and monitor daily setup reproducibility in pediatric proton therapy patients under anesthesia?
So we do online imaging, of course, and that's for pediatric patients, the intracranial and CSI cases. It's mainly focused on oblique imaging. So oblique imaging as part of the IBA system, basically. It's the fast, low dose form of imaging. And it fits that in those indications because we can match on bony anatomy. So it's fit for purpose, I would say. So that's how we do most of our positioning and
and every change we make with the table, we take new pictures to be sure that it's correct. So that's
also for our setup, we calculate as physicists, we calculate what the setup position should be, and then we of course have tolerance tables, and but those tolerance tables are dedicated for each indication type, of course. So that's we don't have them in this presentation now, but you know, the centers who have these questions are welcome to reach out to us. Of course.
Well, it looks like we're just getting warmed up. Quite a few more questions coming in. So we'll go to the next one. This is from one of the centers that says there are generally two types of mold care that we commonly use: normal and S-frame that supports the shoulder. Which do you generally use, and do you face reproducibility issues around the clavicles?
But the mold care is just the head. Most of the time, because we see if we take too much cushion, too much mold care, for us it's more difficult to put on the mask. So they have just little cushions just for the head, and we see that that is very good molded, and that you just can't put the head on another side or a little bit more to above, then the mask doesn't fit. So we just use the head cushion. For the shoulders, we just look that they are a little bit relaxed, but they are always against the mask. So that's one of the indications how we do it.
Okay. Next question. How long will it take to treat one pediatric patient with and without anesthesia? And then how will you manage the patient if the treatment gets delayed?
Yeah, that's a good one. So anesthesia slots are 45 minutes that's how we...
For all your pediatrics, whether they're anesthesia or not?
It depends. When it's a CSI, it's 45 minutes, but for a head, it's a half hour. But when it's delayed, you mean the patient has to wait, or there takes more time?
Well, they don't clarify. I'm thinking, how will you manage the patient if the treatment gets delayed? So I'm thinking they're thinking in your time slot, if something happens with one of that patients, and I think that may be what they're asking.
A good approach is is something that we have, is that we have two pediatric anesthesia slots early in the morning. So they're the earliest patients to come up to our center, which is good because sometimes they have like a protocol where they need to like not eat for a certain time prior to their treatment, to their daily sedation. So it's actually better, you know, to have this during the night for patient comfort, of course. So definitely early slot morning fix anesthesia slots is a good idea. And then apart from that, but that's also due to the hospital setup, we also have 2 anesthesia slots right after our RTT lunch break. Yeah. So in case there's a delay,
we just work through the lunch. We don't get a lunch and we just work because the patients, they have to wait until they can eat.
Right.
For them it's like 8 hours, but for a child of 2 years it's difficult.
Right. You don't feel right taking lunch knowing they haven't. That makes sense.
We eat in the morning, but the children don't.
I know. That's it. So I just want to make sure I clarify. Your slot is 45 minutes for anesthesia patients.
Yeah.
Okay.
Yeah. And maybe we should also note that for all of our patients, we make a backup proton plan that we have available. If there is proton downtime, but touch wood, we don't have that often, luckily.
Yeah.
We can switch to having the patient having their treatment on the photon side with the anesthesia team, like switching around to the photon side. But that luckily doesn't happen that often. But it's a way to not lose those anesthesia slots. So that's a way you can mitigate those things in terms of delay.
Okay, we have 2 more questions that I want to, but I do want to mention that it's so great to hear how you all are so committed to making sure these patients are treated appropriately. And it's nice to know internationally. I mean, that what brings us all together is that same mission, especially with these children, to make sure they're treated appropriately. And that often means working through lunch or doing a little bit above and beyond. So here it says the dose fraction regime follow in your organization for a CSI patient in proton therapy. So I think they're asking what your dose fraction regime is for a CSI patient.
Yeah, so for pediatrics, it's always 1.8 gray per fraction. So, and then for pediatrics, we don't have a doctor here. Our apologies. But there, the prescription is for patients where the vertebral axis is still growing. So the whole vertebral axis receives 20 gray as an additional target volume in order to make the dose homogeneous in that region. So, and then we also have, if I try to explain this correctly, we have either the CSI dose to the full CSI axis to 36 gray or to 24 gray, depending on the stratum of whatever they're in. Reach out to our doctors for that. And then there's a boost to 54 gray most of the time.
Okay. And again, it's all doctor led, of course. And we get that. We want to caution the audience in that sense. The last question, you answered this a little bit, but if the patient's growing or weight loss and stuff, but it says, how often do you do adaptation plans for pediatric cases, and what triggers you to do that?
How younger they are, more we have to change. They like a 1-year-old, it grows fast. With a 6-year-old, it doesn't come very often.
No.
But with a 1-year-old, it's I think most of the time we have to change it a little bit.
Once or twice during that treatment time duration, or?
So since we always do 1.8 gray per fraction for all of our pediatric patients, those treatments, fractionation schemes are quite long. For a 1-year-old patient, we want the patient to still continue their normal development, ideally. So we kind of expect during the 5 weeks after stimulation that patient has grown a bit. So we anticipate and have that communication between our MDs, RTTs, and anesthesia team, like, hey, is this mask not becoming too tight? And if it's
Okay.
kind of coming too tight, okay, we say, okay, well, let's plan a new mask simulation slot.
With really little children, we always have backup slots at our CT simulation. If it isn't necessary, okay, but otherwise we have that slot to make a new mask on CT.
Okay. And again, it sounds like it's very individualized to the age,
Yeah.
the communication,
Yeah.
a lot of individual assessment. So there's no set plan on that.
No.
It's very much a decisions the team is working together to assess and analyze. So that makes sense. I lied. There's one more question. So it's great. It's good that people are really finding value in what you're sharing. So this one says, what is the CSI setup protocol for treatment, such as the imaging and beams? Is that something that you can summarize?
Yeah. Do you want to take this one or should I?
I mean, just with orthogonal.
No, I think they mean, so what we do is we take oblique images, but what we do is, because with CSIs, you have multiple ISO centers.
Yeah.
Mhm.
And what we do is we image first the head, then the most cranial bum region part, make sure that we have our positioning right.
Is right when we have to change. We see that the patient is a little bit otherwise positions. We just take patients and we position them right, and we take new pictures. Okay, is it straight? Is it again? Is it good positions? We go to the next stop, the pelvic area. There we see, okay, it's good. And when the patient is right positions, we go outside and we do the opposite. So we start at the bottom and we go up, and then we have a little bit of changes in our imaging, but it's not a lot.
No.
So
what you
we also take obliques to verify that it's still good, because the table moves the whole time actually.
So what you basically do is you image first the most cranial and most caudal region. If need be, you manually go inside and really just manipulate the patient a bit on the table to make sure that axis is aligned correctly with what we have planned. Then you image every isocenter in between, and then we start our treatment, the posterior treatment fields. And whilst you do the movement from each image from each treatment isocenter, we do re-image. And check.
We take obliques.
I think it's
to verify that it's still good.
Great. Thank you so much. Really great information. I appreciate you closing. I know it's the end of day for you all. Clinic's done. You finished treatments, long day, and you spent your time really sharing some best practices. Really appreciate that.